Okay, so thank you and welcome everyone to today's event. So you've heard from both Sarah Pitt and Anthony Rhodes around the nature of pandemics and the SARS-CoV-2 virus. During the pandemic, I had the ultimate privilege of being involved in the large-scale testing of COVID within the NHS. And for me, I'm going to talk about a story that's slightly personal and of what we did as a country in responding to the pandemic. So first of all, to note is that the outbreak of SARS-CoV, as it was described as a term, a virus from Wuhan, wasn't really noted in the West until about late December 2019, and that's the first mention of it we had. I think I had a formal document noting in a board meeting that we had or were aware of in the West a novel respiratory virus in Wuhan in China. So that was the first time it was mentioned, and that kicked off a whole chain of events within the system. Also I've got to say, so my slides are very small at the bottom, and my slides not appearing correctly. Okay, so it sounds like they're okay. Okay, so that kicked off a whole series of events around management of a potential threat to UK health security, and that's normally run by Public Health England. As they kicked off a series of Thursday afternoon meetings, incident management meetings, where we met every Thursday for a number of weeks to discuss and highlight the challenge that this novel virus might present us. And it's also worth noting, of course, at this point, there was no testing available in the country for SARS-CoV. Clearly, it was capable, and we were capable of testing for the virus in manual methods within Public Health England. But the important thing is that there was no meaningful volumes of tests, and that was true right the way through February. There's also, and I think we have to remember back to the very start of the pandemic, there was a huge amount of uncertainty. I really don't think that actually it was clear in any way, shape or form about what the situation was with the virus and how it was going to evolve in terms of spreading around the world. It was clear that it was a significant virus. I think that was true, and I think we really could see that. But we had no disease course information. We didn't understand what the threat was or the infectious nature of the disease, and we had to keep it under constant review. Now, what we did need to do, of course, is have a UK-wide response to ensure an effective test and trace system. So the public health approach to gathering information from suspected cases in England and what we might do in response to those suspected cases. And then again, if you remember back into those days, we had a number of cases being identified and quarantined in the UK during February. And we had a whole busload of individuals who were kept at Arrow Park Hospital in quarantine to try to prevent the spread of COVID within the UK. Clearly, Public Health England started to expand their own testing capability, so a method was developed, and that was put in place within the public health system to enable a early test and trace approach, which would be normally prevalent in most disease management or infectious disease managements. So I think that was the key thing. It was a very rapidly evolving picture. I think that after sort of several weeks into February, it became clear that in-country community-to-community infections was prevalent, and we were starting to see SARS-CoV-2 spreading around the country very rapidly. And it became clear, and I think I received a phone call on the last Friday in February, as I remember it, from Public Health England asking the NHS now to step up its capabilities to test for COVID-19. And that's no small feat, as you can imagine. This has been managed entirely within the public health system up until that point. And of course, by this point, we were fully aware, we've seen what was happening in countries such as Italy, that very quickly health systems were being overrun with patients who were very sick and very unwell. So the NHS started to move towards a ramped up emergency response. So what did we need to do? Well, we needed to rapidly set up and build a testing capability that actually was not just a public health capability, but also a diagnostic capability. We had lots of people coming to hospital, and we needed to answer diagnostic questions whether they had COVID or not, aware that community and hospital-acquired infection was a very real route for spreading the disease, as we have seen. Like I said, we moved into the emergency response stage. We spent the next few weeks building up a picture of what was capable and what we had in the country, and how we may respond to that. And we were the main purpose of my role initially was to build an understanding of that potential capability, providing advice where we could do, making sure that the advice we give to the system about what they should or shouldn't be doing was being shared widely, and that people were taking appropriate action in terms of testing. So things like making sure that we were using CE-approved kits, which at the time, of course, were in exceedingly short supply, or people were using a public health approved method for testing for COVID, and that required a degree of capability that not all laboratories had. So that's what we spent time doing in the initial steps. So let's talk a little bit about the infrastructure with England. So not everyone on the call will be from England, so they may not what we're doing. But within England, the pathology system, the services within England were in the midst of a reconfiguration into 29 pathology networks, and that gave me an ability really to make sure and communicate clearly to people right across the country. And I know actually a number of people here on the call who are on the webinar side who were involved in those discussions and those meetings. So although our pathology networking systems were immature, there were enough in place, and there was enough leadership in place, both scientists and clinicians, that we could talk as one centre to 29 individuals who could then feed that information out to all of the other services within the NHS in England. And that totals something like about 120 other laboratories who had at some point the capability to do that. And I think the key thing is in that early March period, we were able to contact people, and I sincerely think that actually, if we had not had that system in place, we as a country would not have been able to mount the response that we did respond to the COVID virus. So I think it really was a game-changing capability for us as a country. Okay, so I'm going to my next slide. If my computer will let me move on the next slide, that is. Bear with me. Okay, so like I said, at the start of COVID, when we first moved into the major incident response, my small team, it's about 3 of us, we were deployed and converted into the COVID-19 testing cell, and our sole purpose was to build within the country a capacity and a capability to test for COVID-19. And that meant we also had to identify the supply chain, build sustainability to make sure people had the right training, education, that they had the right kit available to them, that actually we were able to continue to supply reagents and chemicals to people, and swabs, that's another interesting area, and also to make sure that we were able to give to the country a single voice in terms of pathology expertise. There was a whole host of questions being asked at this point about what was going to happen to routine work when the country went into lockdown, how are we going to manage cancer services, how are we going to manage screening programs, etc. And we had to build answers to those very quickly in a very high-pressured environment. All this was coordinated through the 29 pathology networks. And we had what became a very regular cadence of meetings. So we were meeting, it started, I think, about twice a week, and then it went to every day of the week. Sorry, excuse me, skipping ahead slightly. Went to every day of the week. But we were talking as one country to the whole country in terms of what we're doing. And we had some incredibly skillful, passionate, dedicated individuals working in hospitals within the UK who helped me and my team deliver on what was a national emergency. So we had all the people in place. Now, again, let's think about the politics around this as well. So this was a major incident being managed directly by ministers and the NHS. So we're in a category 4 major incident, which meant that the NHS acted as one organisation. The centre directed and told people what was happening and what they should do to respond to that, and they needed to respond to those demands. But the NHS itself, of course, was responding directly to ministerial asks in terms of delivering a safe and secure health system during a time of a national emergency. And the government established a broad 5-pillar testing strategy, and one that you'll be aware of. Now, I'm not going to go into the rights and wrongs of the various pillars that were established to support the testing response in the UK, and I will only really discuss here Pillar 1 and Pillar 3 and Pillar 5. But I think to consider as we go through my talk, perhaps, what could we have done differently is one of the key questions. I suspect the inquiry will ask that question. Whether the government was right to establish a 5-pillar approach to testing will also be a pivotal question that will be asked during the inquiry. And I think we will need to be very careful and considerate in our responses and how we think about what we have done and what we might be able to do in the future in response to any future pandemic. But let's talk about what we did do and what we were able to do. Like I said, the 5 pillars were Pillar 1, which was the public health and the NHS PCR testing. Pillar 2, which was the lighthouse capability, that was the slightly more private sector UK HSA run PCR testing. That's all the home testing and the self-testing. We had the NHS serology testing, so this was the antibody screening for people before we had the vaccine, to know whether people had COVID or not. Clearly, we were seeing a whole range of people who were asymptomatic for COVID. Pillar 4 was around the seroprevalence. So this is really getting a detailed understanding of where the virus is in the country and how many people it's infected. And Pillar 5 is about the UK's diagnostic capability, of which I think we could all agree we did not have much resilience around. So what was the Pillar 1 and what did we do there? Now, for me, this is a hugely proud component of what we did in the country in terms of making sure we had sufficient testing for the country. We worked very hard around the supply chain, and Jane Mills will be joining me later on for a panel discussion, who helped and worked tirelessly on the supply chain to make sure we had enough equipment, reagents, chemicals available to us in the country to undertake this testing. We approached it as you would expect pathology experts to approach any testing. We made sure that we were always using validated CE marked kits for what we were doing, that we could be assured of the performance of the kits, that we had EQA schemes, that we had all the quality components around in place to make sure they worked, so that we could rely upon the capacity that we were building. I think the key thing for me was that we needed to build a capability that served our hospitals and that served those patients within those hospitals, to make sure that actually as many people as possible were getting the right diagnostic answer to the query we had. We worked hard, so don't forget, at first the SARS-CoV-2 virus was a category 3 virus that meant it should be handled in a category 3 level laboratory. We worked hard to work out how to mitigate that and how to make sure that samples could be handled in what we came to call a 2+ containment arrangement that allowed us to get more people in those laboratories to work and provide the diagnostic answer. We didn't actually have an issue with our instrument capacity, and this may well sound an odd thing for me to say, but actually the country had a considerable size of PCR capability available to it. What it didn't have was the PCR reagents, and that really was the biggest stumbling block we had. We didn't have the right ones to serve the capacity we had, and that meant that was a real challenge. And equally, at the start, the workforce was not a major issue. We all pulled together and people converted from biochemists into microbiologists during that time to support the testing capability. So workforce was not initially a constraint. Clearly, it became a constraint when we were running 24/7, 7 days a week. Suddenly, there were not enough people. And I know there are other people in this call who worked tirelessly in making sure that we had a pipeline of scientists coming through to us, so supporting the registration of individuals, extending people's registration to ensure that they could work safely and we could provide the services we do. And we had a couple of ministerial things, and it's one of those unique things about the job I had, was that actually some of the work we're doing was directly related to ministerial commitments. And so I think you'll see on the graph there that we had to build a capability. At first, that target was 10,000 tests, and then it was a target of 25,000 tests by the end of April, and we succeeded in meeting all of those targets. And to give people an idea, that's 25,000 tests per day capability. In 2018, so 2018, 2019, for data that was available for microbiology PCR tests, the country as a whole had only done 900,000 tests. So 300,000 tests. So 300,000 tests in total for real-time PCR for microbiology purposes. We were suddenly doing 25,000 per day. So that gives you an idea of how that scaling we did in that time. And it's incredibly impressive and a demonstration of how biomedical clinical and clinical staff work together in doing that. The work evolved over time. So as it became clear that the scale of the pandemic and the size of the test and trace requirement to keep people healthy, keep people going in a way that makes sense, is that we had to continue building our capacity. We had to work very hard on that one and make sure that we continue to build both a sustainable and consistent capacity. And the aim was that the NHS would build a capability by about October time of about 900,000 PCR tests per day. We also had to start looking at rapid testing deployments, so making sure that we could deploy and build a capability around rapid testing. This was to enable A&E departments to admit people in the right place. And I think that was also quite important to make sure that that A&E departments were not a source of infection, that admission units were not a source of infections. So I think we had to then look at that technology and how we deployed it. And also, as the pandemic went on, bear in mind that this was a huge big bang of things going on, that we need to work out how we can return back to business as usual whilst managing the pandemic. And I think that was really important. We really do. I'm getting messages that people can't see my slides, so I'm gonna stop sharing for a second and then reshare in the hope that you can see my slides. If not, we will go to plan B, which Jordan will share those slides so we can see them. But just bear with me one second. Let's try again. Okay, I'm just going to ask Jordan if he can unmute and tell me whether he can see my slides or not.
Yeah, I can see them, David, but I think people are having issues seeing them.
Okay, Jordan, do you want to start sharing my slides and start? Jordan, I'm on slide 8. If you take over, I'll stop sharing, and then on slide 8. So please excuse the IT problem. I'm not quite sure what's happening and why we can't share screens on that one. Okay, Jordan, could you go to full screen on that one, please? Okay, thank you. So we continue to work hard to make sure that we could deliver a business as usual, and I think during the summer we started seeing activity return back to normal. And also we were responding to other major incidents as well. We had, for those of you who are involved in laboratories will know that we were also involved in some major supply chain issues outside of COVID. And I think that was definitely a major issue for the country. Can I have the next slide, please, Jordan? And you can see that over time we continue to build our capability. So this again is the pillar 1 capability. So by the start of August, July, we were up about 50,000 potential capability of about 50,000 tests, well above our trajectory. Next slide, please, Jordan. And then you heard me say, sorry, next slide, Jordan. And so you heard me saying about the target was to get by October time to about 90,000 tests per day capability within the NHS in England. And you'll see, together with the high throughput testing and the rapid testing is the slightly darker grey box, that we achieved that by some margin, and that was very important. If I can have the next slide, please, Jordan. Now, talking about pillar 3, and this is a different pillar, because actually this wasn't an opportunity for us to demonstrate as a community how you introduce a new test and how you can respond at scale to testing. For me, this is a very proud moment. Now, the antibody testing in itself, actually, it became very clear that it wasn't needed in the way that we perhaps thought it was needed when we were first talking about developing antibody testing. The speed in which vaccines were developed meant that actually knowing someone's antibody status would quickly be lost within a vaccination program, as people would have antibodies raised against the SARS-CoV vaccine even if they hadn't had COVID too. So we didn't need it, but at the time, of course, we didn't know that, and actually we moved rapidly to make sure that we built our armory of diagnostic tests that are required. Clearly, antibody tests are being used, and they are useful, but actually only in limited clinical circumstances. But what we were able to do, because we were able to control this, and we were asked to set this up for the country, we were able to control the use of what capacity we had, direct the capacity appropriately, making sure we had a mixed supply of suppliers, and to make sure that all the kits were CE marked and properly controlled for use. Like I said, the teams involved in setting up this capability, which was 40,000 tests from day one, were exceptional. We went from tests being developed, being validated, being CE marked, and available to the patients within about 2 weeks. And to give you an idea of what that means in terms of pace, it meant that actually kits were arriving on the Wednesday and the services were going live on the Friday in terms of being able to process our samples. We knew full well that actually with antibody testing being run on our mainline analyzers, that workforce was not particularly a constraint. I mean, clearly volumes were important, but it was not particularly a constraint. Capacity on instruments was not a major issue, but the biggest issue was, of course, phlebotomy. Getting blood out of that number of people was much harder than getting swabs from people. I think we've seen a real drive in home sampling in response to that, because clearly if we did need, or if we had relied more heavily upon antibody testing, we would have needed, in this sort of scale, we would have needed a different solution for phlebotomy. So I think, again, an example of a scientifically led process of introducing a brand new service into the country, we definitely were able to show our value there as a profession. And I think we can be very proud of the fact that actually, left to our devices, if you like, we were able to deliver the services at that pace, which is very impressive. Next slide, please, Jordan. So what were our successes? So our successes really were the fact that actually we both maintained and retained a capacity to test for the SARS-CoV-2 virus. We still have that capability and we still have that ability, and that was no mean feat. I kid you not, but I say the number of people I've been involved in talking to and working with in delivering that capacity, the number of people who must have been behind undertaking those tests day in, day out, is phenomenal, and their commitment to our profession and to the work they were doing is beyond admirable. It really is a thing of utter pride for me as a biomedical scientist, and I hope as a whole profession. We met all of our targets, and again, isn't that great to meet all of your targets? For me, that again demonstrates the fact that scientists, when asked to deliver, because we have the scientific method, we have the drive and the ability and do things through a scientific method, we were able to commit to things we could do, and we could do that. We had delivered to the country a universal coverage of RT-PCR. We had universal coverage of serology, and we've built a rapid testing capability right across the country as well during that time. As a byproduct of that, and I think it really is really important, is we raise the profile of our profession, of what we can do and how we can do things very, very well. And like I said, not to underestimate nor to underemphasize the gargantuan effort that our scientists, many of you on this call now, I'm sure, who were involved in testing for SARS-CoV. I think it was a time of utter need. Next slide, please. So talking a bit about the future of diagnostics, like I said, we did not have the resilience that we needed within the country to to respond adequately to the SARS-CoV. We were heavily reliant on other supply chains outside of the UK. And I don't think we should allow ourselves to be in that situation again. And I'm very pleased that the government continues to have that view as well, which is very good. We have raised now the situation where there are people who have a real and genuine interest in diagnostic technology and the use of diagnostics within patient pathways. We're seeing novel technologies fast-tracked and brought into service at pace. So those of you involved in digital histopathology will know that lots of money going into that area. But also understand the importance of making sure there's scientific rigor around that. And I think there's lots of questions being asked around how does the government and how does the system, how does the infrastructure ensure that we don't have tests that do not serve a purpose on the UK market? And how do you make sure that we monitor those tests that are on the UK market to make sure they work effectively? My view is that networking has been a key enabler of that. And I think that's important. But also another benefit of the pandemic has been we've understood or demonstrated the importance of having data connected, being able to supply data, stream data into the patient record, to share that data with those people who need to know that data across the board as being vital. And we've seen the adoption of systems such as NPEX become almost universal overnight. Because of the need of sharing that data. And I think that, again, that was really important. Next slide, please, John. So we're now moving into a recovery phase, and we are still in the recovery phase, and we will be in that recovery phase for some time to come until we have delivered and cleared our backlogs. But we still have a capability to deliver testing for COVID. That will not go away, and that requirement will remain with the NHS for many, many years to come, if not forever. We're now working out how we tackle the backlogs of patients who were not seen when they need to be. And again, people are seeing diagnostics, they're seeing biomedical and clinical scientists as the route to make sure we get through that backlog as fast as possible. So a real opportunity for us to deliver that. And then my next part, really, and of course I would say this, wouldn't I, making sure that we achieve the aspiration of those pathology networks so that we can build that resilience into the UK in a way that we didn't have at the very start of the pandemic, and that we can respond in a way that actually our patients should rightfully expect of us. Next slide, please, Jordan. We've also had a lot of money going into the system, an awful lot of money going into the system, and we've had that both concentrating in workforce. We've seen it being funded for things like digital histopathology. Many of you will have investment in your LIMS upgrades, etc. So we know there's a lot of money going into the system, and that is because we demonstrated the importance of these items during the pandemic. Like I said, for England, for the first time ever, Health Education England is now grant funding most of the qualifications the institutes provide, and that's a unique outcome from the pandemic. I don't think that would have happened if we had not have demonstrated our value during the pandemic. And like I said, the IT systems again are also pivotal in that. If I can, next slide, please. So personal reflections. Well, again, this is for me. Like I said, it was a challenging time. I think I say this, and I'll say it again and again. I think pathology services rose to the challenge. Teams up and down the country worked collaboratively in a way that actually you could only ever dream of. I expected, and I did expect it to happen, and it did, and it's very assuring of the professional nature of our profession. It was very hard work, and I say this. I was only one person, but actually, There were teams who were working 7 days a week. I think I spent the first 2 months working 7 days a week, and then until we got to a rota system where I could take it 1 day off a week. And then when we got to that point, we were able to go, and I think I had 2 days off in an 18-month period. And I think I Boxing Day and Christmas Day. And I worked for the testing cell from its inception through till the end of May 2021. That's a very, very proud things. And I got the chance to chair and take part in meetings and build friendships with people as well that I wouldn't have done otherwise. Next slide, please. What else did I do? Well, I had an opportunity to speak to the Prime Minister on our profession's behalf. I met with Matt Hancock and other ministers on a regular basis, working with JBT and other government scientific officers. We worked with some, and I mean this, phenomenal individuals. There are some people, and it'd be wrong of me to even try to name names because there's so many people who pulled out of the hat some phenomenal work, some really dedicated professionalism at a time that was at need. And it really was an opportunity that actually uniquely as scientists that we were able to serve our country. So I was very proud to serve my country in that time of need, and I know so many of you others also. And also, of course, we were able to use our expertise in doing so. Next slide, please, Jordan. Last couple of slides, and I promise I'll finish. It was also a very, very challenging time, and it was a time of a very, very steep learning curve. Working with elected officials, so working with parliamentarians, ministers, etc., means that they listen to your advice, but they don't need to take it. Even if you plead with them to take your advice because you think it's right, they will not necessarily take your advice, and that is a very challenging situation to be in. And I suppose I'd reflect now, of course, with the inquiry coming, those ministers quite rightfully will be held to account to their decision making. And me as an expert, my job was to advise them the best I could in what I knew and what I did. And it was their job as the elected representatives to make choices on behalf of the country. So again, that's an interesting but challenging thing to get your head around. But then, of course, when it comes to the inquiry, you can see why perhaps an individual will be held to account. They did change their minds and their plans very quickly, and I remember many calls where we would say to people, day one we will be doing this, and the next day we'll be saying something completely different, and that's again very challenging to get people. And I know full well that actually on calls there were very emotional calls actually sometimes when we've changed things so rapidly that people can't keep up, or they need to commit their teams to some very hard work to meet those requirements. It was very challenging to be one of the very few experts working in that space, but I will also say I was very thankful for some very sage friends who took my phone calls all sorts of times of day and night as we talked through problems and talked about how to approach things. I think that for me was also an area where the community pulled together to support each other in that regard. And I was incredibly proud of my team and the whole pathology community. It really was quite wonderful. And if we go to the next slide, please, Jordan. An example here, really, I got to work with the military. So there was a couple of lieutenant colonels and majors who I worked for. There was a guy who was a submarine commander who brought me a cup of coffee because that would keep me at my desk and keep me working. And I had a major who was designing Excel spreadsheets for me just to keep on top of all the work we were doing. So, unique opportunities to work with some people from very different areas. If you go next slide, please, Jordan. A cartoon popped up during the pandemic. If you can read it, it says, we're in danger of missing our target, so we need to test you for 32,000 times. I will tell you now, without saying any more, than that was very, very close to the truth. Very close to the truth. We're out looking for people to have swabs, but I won't say any more about that. But it's obviously satire is obviously sometimes very close to truth. Next and final slide, please. Clearly, I got to meet and work with some wonderful people, and this was, for me, a huge honour that the Royal College of Pathologists honoured me with an honorary fellowship of the college. And by chance only, I'm sure, but I got to sit next to Sir Chris Whitty as he received his honorary fellowship as well. So for me, a very proud moment. And I would say, and to finish, and I cannot underline this more, that actually it's a very proud moment for us all as a profession. We did an awful lot to serve our patients, and we brought us to the fore. And my commitment to you, in return for all the help that you gave me, of course, is that we will continue to drive to raise and maintain the profile of biological scientists, not just in SARS-CoV, but in every element of diagnostics. So I shall end there, and Andrew, back to you.
Oh, Hugh. Thank you, David. Oh, have we got an echo there? We have. Not sure where that's come from. Let me turn my...
I can hear you normally, Andrew.
Okay, how does that sound? Does that sound
That's
good?
fine.
Oh, great. Well, phew, thanks, David, for that remarkable view of behind the scenes what was going on. Of course, we're all stuck at our computers and our benches and our analyzers without knowing exactly what the country is doing in response to this terrible pandemic. I'm hoping we're going to get a question or two. And whilst Jordan is looking at that, I've got a quick question for you. Right at the end, you mentioned the college. Of course, the IBMS has been getting closer and closer to the Royal College of Pathologists over the years. Can you tell us how your interactions with the college helped with this particular work?
Well, so interestingly, twofold, I suppose. The relationship between the IBMS and the Royal College of Pathologists is a very, very good one, a very strong one. And I think I probably talk to the current president on a weekly basis, at least, and our president talks to Mike Osborne on that same frequency. During the pandemic, the National Specialty Advisor, Professor Joe Martin, was also at the time the current president of the Royal College of Pathologists, and Joe was part of my wider team. So we did work very closely with the Royal College during that time. We also worked very closely with the IBMS. As you'll know, that Alan Wilson, the then president, was very vocal to make sure that the needs of our profession were being heeded and were being flagged at the highest level. And so together, the NHS, the IBMS, the RCPath, we worked very hard to make sure that there was a lot of visibility, and that what we did was actually complementary and not causing problems for us as a profession.
Right, thanks. One last question from me. We don't have any others, I'm glad to say. You mentioned the inquiry coming up at some particular time. What do you think the Institute's role in that inquiry will be, and how will you build a response to the potential questions?
So we're already involved in the inquiry. So we clearly are a very interested party in the inquiry, and we've already been approached by the inquiry team and have submitted quite a detailed response to the first module, which is around preparedness of the country into the inquiry. I'm probably not wise for me to say what in detail we gave to the inquiry team. In the fullness time, clearly that evidence will become public and people will see what we've said. But at least to say that we have championed and made clear our points that the government did not necessarily seek to use the profession in the way that it could have done, did not necessarily seek to use experts in the way it could have done, and that we were able to, we could have done further and more, we would argue, if the Institute had been involved sooner.
Okay, thanks for that, David. As it happens, we do have a question from Mark Tovey in Sheffield. Jordan, can you find what the question is? Can you put him online?
I think I've got access.
Hi, Mark. What's your question, Mark?
It's just a comment, really, where you were talking about the evolution of the lab response at the beginning, and you talked about the use of only using validated tests. I just thought that perhaps you missed a trick there, because at the very start there were no validated tests, and Collindale had to develop them, and we in Sheffield ran and developed one at the same time at the same rate as Collindale. So it wasn't a case of using validated tests; it was actually creating them from scratch.
Yeah, well, so to respond to that, Mark, and there was a particular challenge around that one. So when when the testing was handed over to the NHS to start, PHE wanted us to use their particular validated protocol. Those of you who will be aware of this will know that actually very quickly it became clear that protocol was not necessarily as good as it needed to be, and it was a policy decision that rather than seek there to be other methods out there, that we would push for commercially available assays that were we would have more assurance around as a country. So you're right, there were other assays available, and people were using their own derived assays. And in fact, actually, the various methods on some of the open access systems were clearly homegrown, in inverted commas, using CE marked reagents. But it was a policy decision on the basis that we had the issue initially with the early PHE method, which was not as sensitive as it needs to be. So that's partly why. But you're right, there was an opportunity missed, but there was a confidence issue as well that needed to be addressed.
Okay, great. Thanks, David, and thanks, Mark, for that. I gather we have another question from Dan Smith, which will be our last one. Jordan, can you put him through, or can we find Dan's question?
It will be it's in the Q&A, Andrew.
I can't access that myself.
Okay, he says, at that very early period, with hindsight, should we have expanded testing from Public Health England earlier in February?
So, I mean, isn't hindsight a wonderful thing? Clearly, with hindsight, you would have said that actually there should have been more work done sooner in all laboratories to build a capability. I think with hindsight, I think the cautious nature at the start of the pandemic meant that actually we did not. Again, I should say this very carefully, not to prejudice myself, but we did not, as a country, respond fast enough for what was already a rapid response. So we already responded exceedingly rapidly to the testing requirements. If we'd had an extra couple of weeks to run at it, yes, that would have made a difference. But I also wonder whether that would have driven some of the urgency down earlier on, and that may well have meant that we'd had a different system. So, with hindsight, yes, there should have been more testing sooner across more of the country. But would that have driven a different response, a different capability? I don't know. And different level of organisation. We were not in the command and control major incident at that point, so it may have driven a different outcome. So we have to be very careful to balance these things up.
Okay, great. Thanks, David, and thanks to our questioners.